Good morning, everyone. So thanks Purvish sir and Amish sir for this opportunity. So I'll be presenting 4 trials, practically 5 trials on gastrointestinal cancers. So these are the trials which are being presented: the atomic, FOXTROT and NICHE-2, and BREAKWATER, and the hepatocellular carcinoma intermediate stage trial. So the first one is the atomic trial. This is a phase 3 trial of adjuvant chemotherapy with or without atezolizumab in patients with stage 3 deficient DNA mismatch repair colon cancer. We all know that. So for a deficient mismatch, so immunotherapy has shown good survival rates in the advanced disease. So this is one of the first trials which has tried atezolizumab along with chemotherapy in the adjuvant setting. So why? Because so the recurrence rates occurs in 30% of the patients with stage 3 colon cancer receiving treatment with adjuvant chemotherapy, and we all know that MMR deficiency can happen in 15% of the colon cancers, and we already know from the previous trials that it was associated with 5-fluoropyrimidine resistance. So, and whereas immune checkpoint inhibitors are approved for deficient mismatch repair cancers, and their efficacy in stage 3 colon cancer is unknown. This is the study design: FOLFOX6 FOLFOX6 plus atezolizumab in stage 3 colon cancer, and atezolizumab 2 weekly was given till month 12 with a primary endpoint of disease-free survival in the intention to treat population and secondary endpoint of overall survival, and well matched. So majority of the patients had a high risk. So almost 54% had a high risk stage 3 colon cancer. So adequately exposed to the chemotherapy. So the median amount of cycles of 5-fluorouracil and oxaliplatin received were around 10 to 12, and atezolizumab also median dose percent received was 96. In the intention to treat population, the disease-free survival was different by 10%. It was 76% in the chemotherapy alone group, and it was 86.4% in the chemotherapy plus atezolizumab, with an absolute 3-year disease-free survival improvement of 10%. So the median follow-up for OS at the data cutoff was incomplete and may be confounded by the later immunotherapy use. So all subgroups benefited with the use of atezolizumab, and safe. We all know the adverse effects, and majority the side effects are well tolerated, and these are the various adverse events in more than 35% of the evaluable patients, and majority are chemotherapy related, and even the immune related side effects are quite less. And the phase 3 atomic trial use of adjuvant immunotherapy significantly improved the disease-free survival alone in patients with stage 3, and safety profile was consistent with established safety profile, and increase in non-febrile neutropenia was manageable. And investigator concluded that so this is the new standard treatment option for the patients with deficient MMR stage 3 colon cancer. The second trial is in the preoperative setting. That was in the adjuvant setting. This was in the preoperative setting. So the FOXTROT is the preoperative chemotherapy and targeted therapy, but the targeted therapy population was less. The panitumumab was used in KRAS and wild type, but the major trial was in the preoperative chemotherapy, which is a 2x2 factorial design, randomly allocated to neoadjuvant chemotherapy, surgery followed by adjuvant chemotherapy versus surgery followed by adjuvant chemotherapy, which was a standard. And the chemotherapy was given for 3 cycles, that is 6 weeks of chemotherapy followed by surgery followed by remaining adjuvant chemotherapy. So this was published almost 2 to 3 years back, and the risk of recurrence was strongly correlated to the histological regression. So there was 5-year recurrence was 30% for those with no regression, falling progressively to 22% in the mild, 13% in moderate, and 7% in marked, and 0% in the complete regression categories. And the primary outcome, residual or recurrent disease within 2 years, occurred less often in the neoadjuvant chemotherapy patients, that is 16.9% versus 21.5% in the control, and this accounted for 28% lower recurrence rate with neoadjuvant chemotherapy. The only strong association seen was the mismatch repair status. The moderate or greater regression was seen in 7%, only 7% of the mismatch repair deficient compared to the 23% in the proficient population, and there was no apparent reduction in the 2-year disease recurrence in the neoadjuvant chemotherapy in the deficient mismatch repair population. So the only subgroup of population which didn't benefit was the deficient mismatch population. So this is the neoadjuvant immunotherapy. So that is the background for the neoadjuvant chemotherapy, which didn't show much benefit in the MMR deficient population. So this is the neoadjuvant immunotherapy in locally advanced mismatch repair deficient colon cancer, the 3-year disease-free survival. The initial publication was in NICHE on the pathological response rates. There was excellent pathological response rates with only 2 doses of nivolumab and ipilimumab. So this was the 3-year disease-free survival. And this is the first trial of neoadjuvant immunotherapy for locally advanced mismatch repair deficient colon cancer. So this is the first cycle is with nivolumab and ipilimumab, 3 mg per kg of nivolumab with 1 mg per kg of ipilimumab, and the second cycle consists of nivolumab. And after that, the surgery was done, and the primary endpoint was the safety, which was established in the initial results, and the other primary endpoint was the 3-year disease-free survival. So this is the population. The T4 accounted for the population. So majority of the population is in the locally advanced, and these are the initial publication in the NICHE-2 where 98% of 111 patients in the efficacy analysis, where the major pathological responses were 95% and the pathological complete response was 68%. That is 7 out of 10 patients has a pathological complete response. And this is the latest results of 3-year disease-free survival, which was 100%. And there was another analysis, the ctDNA analysis. So the ctDNA analysis was done at the baseline after 2 weeks and pre-surgery. So after one cycle, so majority 45% of the patients cleared the ctDNA, and almost 83% cleared the ctDNA before the surgery, and those cleared the ctDNA has an excellent outcome. So at the MRD time point of 3 weeks after the surgery, ctDNA was negative in all the patients. So, and finally the outcome was the 3-year DFS was 100%. Another trial is the BREAKWATER study. So the encorafenib, cetuximab and chemotherapy in BRAF mutated colorectal cancer. We all know that the BRAF mutated colorectal cancer will do extremely bad, and these are present in 8 to 12% of the metastatic colorectal cancer cases. And first line chemotherapy with a biological agent, preferably bevacizumab, what we use, is less effective for these patients. So this is the first trial which targeted the BRAF pathway with encorafenib along with cetuximab, because they are shown beneficial in the later lines of BEACON trial. So in this trial, the metastatic colorectal cancer patients were randomized to 3 arms: encorafenib plus cetuximab, or encorafenib plus cetuximab plus chemotherapy, or the standard of care, with a primary endpoint of progression-free survival and the overall response rate, and the key secondary endpoints were the overall survival. So the progression-free survival was different by approximately 5.7 months. In the standard of care group, it was 7.1 months versus 12.8 months in the chemotherapy plus targeted therapy, that is the encorafenib plus cetuximab. But the only without chemotherapy, the encorafenib plus cetuximab arm did almost similar to what was the standard of care. The progression-free survival was only 6.8 months. All the subgroups benefited with the combination of chemotherapy plus encorafenib and cetuximab, and this is the overall survival. So overall survival is almost double, that 15.1 months versus the 30.3 months. And all the subgroups also benefited for the overall survival. And these are the toxicities. These are the toxicities majorly due to the chemotherapy. And the few side effects like pyrexia, rash were seen more common in the encorafenib cetuximab group compared to the chemotherapy group. And this is the last trial where I am discussing, which is the IKF 035 ABC hepatocellular carcinoma trial. This is a phase 3B randomized multicentral open label trial of using atezolizumab plus bevacizumab versus transarterial chemoembolization in intermediate stage hepatocellular carcinoma. We all know that in advanced stage, so the atezolizumab bevacizumab combination has become the standard of care with the IMbrave trial, and now this has been tried in the intermediate stage HCC. And this is the common treatment algorithm shows that for an intermediate stage HCC, now the standard of care is the transarterial chemoembolization. So this transarterial chemoembolization is compared with atezolizumab. The main inclusion criterion was the intermediate stage HCC, which is not amenable to curative surgery, liver transplantation or curative ablation, but disease should be amenable to test, that is minimal vascular invasion, that is VP1, VP2 or allowed. So the primary endpoint was the time to failure of treatment strategy. So that could be, so the radiological progression in the AT-BEV arm. In the TACE arm, it could be a radiological progression or even a stable disease. Or another thing would be any of the following, like loss of clinical benefit or unacceptable toxicity or liver function deterioration or therapy not further applicable for other resources. So this is the primary endpoint which was analyzed, the time to failure of treatment strategy, because it allows a fair comparison between the two modalities. One is the loco-regional therapy and the systemic therapy, and the secondary endpoints are the overall survival and the progression-free survival. And this is the first interim results at a data cutoff on the June 2025. And the baseline characteristics are well matched between the two groups, and this is the time to failure of the treatment strategy. So the median time until event was 14.59 month versus with atezolizumab bevacizumab versus 9.46 months with the TACE. And this is the exposure. The median number of chemotherapy cycles received were the 12, and the TACE cycles median received were the 2 with a range of 1 to 8. And these results show that the first interim analysis provide important insights into the efficacy of this combination of atezolizumab, bevacizumab versus stage in intermediate stage HCC. And based on these findings, the trial is progressing to the second interim analysis at 66% information fraction. And these signals suggest superiority of systemic therapy compared to TACE in regard to time to treatment strategy in intermediate stage hepatocellular carcinoma. Thank you.
Thank you, Stalin. We have now 2 panel discussions, 30 minutes each. The first panel discussion will be on atomic and ABC HCC, for which may I request Dr. T. Raja sir to moderate the session. I'll call upon panelist Dr. Safalta Bagmar, Dr. Shifali Sardana, Dr. Manoj Mahajan, Dr. S. Krupashankar, sorry, I confused. Dr. Barnini Ghosh, yes. Dr. Ritu Jain, Dr. Swaratika Mazumdar, Dr. Neelam Singh, Dr. Shruti Gohel, and the last person whom I'm going to invite, in fact, he and me, we were together in Bombay last week. And when he saw the agenda of this OBTO, he said, sir, I also want to come. And I said, it is our honor to invite Dr. Viraj Lavingya. Dr. Viraj, you have to sit in the center according to moderator.
So, first of all, I know Dr. Amish and Dr. Parikh. So, Dr. Amish, thank you so much for inviting me to be here. It's always a pleasure to be with you in the OBTU, and which I think is one of the most seminal events in the calendar of oncology. And thanks to Dr. Parikh also for including us here. And 2 studies, the atomic and the hepatocellular carcinoma studies. What we are trying to do, it was well presented by Dr. Stalin. What we are trying to do is that whether we will take it forward to our clinical applications, yes or no, and then maybe how do we look at pros and cons. The atomic study was presented in 2 major forums in 2025 itself. The primary analysis was presented in ASCO 2025, and then there was a Lynch subset analysis in ESMO 2025. As was already mentioned, 37% of the patients have stage 3 disease, out of which 11 to 18% of the patients have deficient mismatch repair deficiency. And currently, their 3-year disease-free survival is 75 to 85%. That number is important with whatever we do current standard of care. And as was mentioned already, immune checkpoint inhibitors are currently approved in the metastatic setting. So I'll start off with Dr. Viraj. How common is this deficient MMR in stage 3 colon cancer, and how commonly do you see this? And can you just quickly talk about the MSI high patients in the early colon disease and in the advanced colon disease?
Yes, sir. Thank you. So we don't check MSI for treatment purpose for stage 1 at our center. It's only for genetic testing or hereditary counseling purpose. So I don't know the number off my head. But from stage 2, I think it's around 10 to 12% where I was working before in HCG. Stage 3 drops down to around 7-8%. And stage 4 is, like rightly said, 3 to 4%. That is what has been my experience.
So 11 to 18%. So you agree generally 15% plus is the population. Now, what is this mismatch repair deficiency? These are the genes or proteins that preserve the genomic fidelity. 4 of them are recognized, and when any one of these protein is deficient, the microsatellite regions are prone to become more mutated. They become phenotypic hyper-mutated states, and we often DMMR and MSI high are interchangeably used. So then question is, how do we establish this diagnosis in our patients? So Dr. Shefali, so how do you do, and when do you do? Now with the advent of all these data, particularly the niche included, would you always want to do MSI in all your colorectal patients straight away?
Yeah, so like Viraj rightly mentioned, so typically in stage 2 onwards, and especially in stage 3, 4, we do MMR by IHC as a standard of care in every patient. Because we know only 5% discordant rate is there between the IHC and the other modalities like PCR or maybe NGS. So as a routine, it's IHC always.
So you're happy with good concordance, that's what you mentioned. So
Yes, sir.
IHCs, and you would agree that we should definitely do in all our patients.
Yes.
So you, Dr. Ritu, you also agree with that statement. Straight away, like pathology, and you ask for MSI in all your colorectal patients.
In
Is that
stage 3, I wouldn't ask unless the panel and it's the part of the histopath. In stage 3, I would, right now, I don't ask.
right now you don't ask? Okay.
Unless the patient is high risk and there's a strong family history, then. But in routine practice, I'm not asking.
Okay, okay. So now this is the primary analysis in ASCO 2025, very elegant design. So modified FOLFOX6 as the comparator arm, plus atezolizumab, as was mentioned, you continue it for just add a drug, see whether it is getting better or not. That's the design. And the statistics were, they aimed at a DFS of 84%. So you already saw 75 to 85, that's the number. That's why they wanted a 84% to give the power, and they tried to target 700 patients. And the study has already enrolled 712 patients and started in October 2017, and the accrual is closed in 2023, January 2023. As was mentioned, second interim analysis. Now, these are some of the things that really happened as the study went on. Number 1, fewer patients completed treatment per protocol in the investigator arm, investigating arm, modified FOLFIRINOX plus modified FOLFOX6 plus atezolizumab as compared to the chemo alone. That's 1 point. The second thing is treatment-related grade 3 adverse event was 71% in the investigating arm as compared to 62% in the comparator arm. So that's what has happened. So we'll come to that. So I'll go to Dr. Barnini. So at the start, this is what happened. You see that fewer patients could complete, and grade 3 adverse event of 71%. So what is your quick impression when you see this?
Sir, I think regarding the high number of grade 3 plus adverse events, sir, we should be careful in selecting the patients selecting the patients before taking them up for treatment.
So you want to, how do you want to select when you look at this adverse event? How do you want to select? You said you want to select. How do you want to select?
Yes, sir. I think we should look at the performance status of the patient, the age and the comorbidities. All this should be taken into account.
Okay. The other things that happen in the study, the baseline characteristics. Fortunately, the T3 and T4 and N2 tumors were well balanced, so there is no trouble with that. Now, chemotherapy exposure was also not compromised in both the arms just because of the addition of atezolizumab, so that is good. So we come to this primary, endpoint analysis. So DFS, the DFS was 86.4% as compared to 76.6%. So the conclusion, or what the authors would say, the primary endpoint was reached in the atomic study by the addition of this, and there is a 50% reduction in the likelihood of disease recurrence or death. And again, fortunately, there was a high concordance when it was centrally checked out for the DMMR. So they confirmed the DMMR both at the site and also there was a central reference lab confirmation. So that's something important. We'll come to that. So I would ask Dr. Swarathina. Yeah, please. So what do you think about this primary endpoint? Does it look attractive? And you want to consider this for your patients if you have a stage 3 and then you have a deficient MMR patient. So what is your take today?
So I think in colon cancers, we shouldn't accept DFS as an endpoint, especially in stage 2 and stage 3. Having said that, I think, it is technically a positive trial, but now that we know there's niche and everything, there are better strategies for treating a DMMR stage 3 colon cancer.
So my question to you is that, niches will come to that. Just the DFS, you said that you are not happy with the DFS alone, but historically for more than a decade, at least after routinely doing the MSI high in these patients, it has never gone beyond that 80% cutoff across the globe historically. So does that matter to you?
It does, because with addition of immunotherapy, you're obviously exposing the patient to an expensive drug, if not necessarily a more toxic drug. You'd expect a better DFS from immunotherapy in a solely DMMR population.
Okay, so still you want to hold on for a minute with this. So I'll come back again. The 3-year DFS was 86.4% in the investigating arm as compared to 76.6%, and the hazard ratio was 0.5, 95% confidence interval, and the DFS benefit was across all the pre-specified subgroup, including similar to the intent to treat population. So there was no trouble as far as the statistics goes. If you just look at the statistics, this looks like a clean presentation, clean trial, clean design, and then you show a clean superiority. So that's what has happened in this trial. So I'll come to Dr. Neelam.
Sir, sorry, sir.
Yeah, yes.
She said she's not okay with DFS as
DFS.
primary endpoint.
Yeah.
Do all other panelists also? No.
Okay, Dr. Neelam, you can take that and you can continue that.
First, sir, I think in this particular subset, we didn't have any other option. This is one of the trials that now that we have an option of adding an atezo in this subset. So yes, I would DFS is quite a good endpoint that we can take. But yes, these are the set of patients who are going to be living longer. So overall survival data is something that we do really need. But yes, in this particular subset, we didn't have a lot of data. So yes, this is something that is encouraging.
Dr. Shafalta, you wanted to say something and then...
I would be starting this practice. I would be adding immunotherapy in the DMMR patients because this is the first time it has shown a DFS benefit in this setup. And we have been using immunotherapy left, right, and center. We'll be able to manage the side effects, toxicities.
So number one, what you say is that you are happy with the DFS. Number two, what you are saying is that the immunotherapy is well practiced. So toxicity profile is clinicians' day-to-day bread and butter. That's what you are saying. And so you are not yet worried about the OS being not shown in numbers clearly. So this is exactly the overall survival data is immature, and again, as I think Dr. Stalin mentioned, the overall survival comparison may be confounded by subsequent immunotherapy because all these DMMR patients definitely on progression are going to get some amount of immunity. There's no doubt about that. So that is the trouble. So now I'll ask Dr. Shruti Goel on that. Now with the OS argument and the DFS being acceptable to some and not acceptable to others, but remember it's 86%, never shown at this number historically so far. So what is your take?
Sir, I agree with Svaitika madam that if given a choice, neoadjuvant immuno would be a better choice. We saw the Chalabi plots, sir. So there, like we are seeing OS, which is reaching like 100%, sir. Pathological response is 98%, major pathological response is 96%. So that is the strategy which I would want to go. If then surgeon directly sends the patient, then this is what I would definitely select over just going for chemotherapy, sir. Also, sir, there is a parallel paper where they did KM subtraction, where they saw that even for proficient MMR patient, the graphs and the results are exactly same, sir.
We'll come
with
to that.
hazard
We'll come to
ratios.
that. Yeah, that's a very interesting twist of what they did. We'll come to that. So, I mean, just, yeah, Madam Ritu, you want to say something?
Sir, I mean, I'm sort of in between.
Okay,
Like
you are actually in the middle.
Okay, no, the data is promising, but yes, there will be a discussion with the patient with this data. But whether I will jump for all patient, I would wait for some more data. But yes, in the treatment discussion, I would definitely discuss.
With regard to data, I don't know what more you can wait, and that's the trouble. The DFS has been done, the exam has been done, and the mark is already given, the pass mark, or probably it's, I don't know whether it's A or close to A, I think, not A plus, has already been scored. And you are not going to get the OS difference because everybody is going to put some form. So this is what you have. So, and toxicity, just let me quickly, and then I'll come back to you in a minute. The toxicity profile is slightly, definitely numerically more here, but most of these toxicities are well known. That's one of the arguments by the authors. And from the existing profile, and then as was already pointed out, relatively well managed. So, and most of the immune-related, were well managed, except diarrhea was the only major issue. So that's what, and so therefore they would conclude Atizo plus the standard of care is practice changing. So this is a late-breaking abstract in ASCO 2025, and it's a plenary session. So we'll come back to. Now, Viraj, what is your take, and how do we assimilate this from what is given so far?
Right. So it is practice changing in the sense that if we are dealt with a patient who has been resected and then comes to us, this is a strategy one should follow. However unfortunate it is, but if it is resected, chemo plus IO is the way to go, and there is no two ways about it.
If it is resected, but as you rightly said, most of them are going to be, as somebody pointed out, the gatekeeper is the surgical team, and definitely there will be MDT discussions, hopefully.
Correct. So many institutions have started doing MDTs, where we are forcing MMR for all patients on diagnosis as a reflex testing. And some of them will change, especially if you see a clinical node positive on the scan. We do agree NICHE-2 does overtreat many patients. You know, T3N0, I don't want to give NICHE-2 strategy, but that's when the caveat of
I think you have capsuled correctly. If they are already operated and they come to you, this is the best you have. That's what right. You want to conclude. Right. Okay, just to finish it off, round it off. The further analysis, subset analysis on Lynch patient was presented in ESMO 2025, and approximately a quarter of the patients were Lynch syndrome patients. A quarter of the atomic were defined to have Lynch syndrome. So I'll just stick with the endpoints alone. These are the endpoints. So definitely the PFS superiority is there in both the Lynch and in the non-Lynch patients. And I mean, this is the hazard ratio and the forest plot. And the conclusion is that the benefit was numerically greater. The benefit, the immunotherapy was numerically greater in non-Lynch patient, though the test of interaction was not statistically significant. So that's the conclusion. So that's where we stop with the data. And I'll take Dr. Chirag Bai's question and come back to you, Viraj.
The question is to just anyone who can answer the question. Can we extrapolate the data of this trial to 4 cycles of capox and atezolizumab
4 cycles of capox and
instead of
atezolizumab.
Folfox,
For the clinical.
Okay.
shorter chemotherapy?
So we'll try to touch upon that. So we will reverse the, order. Shruti, what is your take on this at this point
I
in
just
time?
wanted to make a point on lynch versus non-lynch.
Yeah.
There have been 2 data sets which have shown that lynch MSI has a subdued response to IO, and it may not be just by chance. We need more investigation into this.
Okay. That's also.
I know, so it was not by chance. There is something happening there.
Some,
There are 2 more
some
data sets showing
mechanisms
the similar phenomenon.
and that's what he says. So we will cover we'll try to now touch upon the landscape as was pointed out and then come to whether we can conclude on based on this. The PACE trial is the, as what Chirag Bhai was trying to ask, but of course it's a little twist. This is capox only versus you have the sintilimab. So very interesting. Let's see, the accrual is going on. So in the same subset of patients, so let's see what happens. And then where did this all come from? This is the 8HW in advanced disease and the NICHE in the locally advanced disease. This is the most famous progression-free survival curve in the advanced disease. Such a big separation, everybody knows that. And in the neoadjuvant setting, as was already pointed out by many, everybody has fallen in love with NICHE-2, Dr. Chalabi, and the data was well presented. The major pathological response, 98% patient underwent surgery and then major pathological response, famous waterfall plots. And then in the same ESMO 2025, this 3-year analysis of these patients, if you just look at the NICHE-2 patients, the DFS is 100%. And as Dr. Stalin pointed out, the FOXTROT patient with another neoadjuvant is 80%. And let me just say this one. So in the NICHE-2, the T3 patients have a DFS of 100%, and the T4 patients have a DFS of 100%. With chemo only possibility in the neoadjuvant, if you get to do 84%, and if it's T4, 70%. So these are what you have to keep in mind. This is what you have, and therefore what you want to do with atomic will be the question. And somebody, the Chinese group did a very interesting, I think, artificial intelligence on this. They tried to do what about proficient MMR? How did they decide this proficient MMR is by this? They reconstructed the same data of atomic, and if the patient was centrally confirmed as DMMR, they are DMMR patient. And if the patient was not centrally confirmed, then they would say that they are proficient MMR or close to proficient. That's how it's a data within the data what they did, and then they tried to see what they call interaction, and then they say that this works in both PMMR and DMMR. I think it's a beautiful jugglery. I don't know how far I'll be happy with that, but that's what it is. Now coming to atomic pros and cons. So what are the pros and cons?
Sir, can I make a point? That
yeah, please.
Because we have a randomized phase 3 trial of atezo plus cobimetinib in PMMR stage 3, completely zero benefit. So this is again a spurious finding, and I don't think so. The message should go that if you have PMMR, along with FOLFOX, one should give IO.
Not yet, yeah. So the mechanism to break the PMMR fortress is still not there.
It's neoadjuvant, but certainly
anywhere,
not
in general. I think you are, the other day you were telling me you were doing the STING trials, STINGs and other mechanisms along with immune checkpoint inhibitors.
In neoadjuvant setting.
Any setting. That's the way to break the PMMR fortress. That's what we understand. So the pros and cons quickly. The DFS has been shown, and it's clearly targeting a precision medicine background, and it is called as practice changing, and it was presented in plenary, and it has come into the NCCN guidelines, whether you like it or not, as versus toxicity, over treatment, and most important thing is other trials are competing, financial burden, and whether I can get my patient chemotherapy free or not. So that's what quickly I will start off with in the reverse. Dr. Shruti Goyal, what's your take? You want to take it forward to your clinic, yes or no?
Yes, sir.
Yes, almost in all patients.
Yes,
Without, so I'll dot Neelam Singh.
Same, sir. I believe the DMMR subset, yes.
Yes. Dr. Swartana.
Yes, I already said yes.
Already said yes. Dr. Barnini.
So, acha. So my take would be not a blanket statement for everyone, but
Okay.
of course the high risk T4 and 2 type of group definitely yes. Now T3N1, I may prefer to do a ctDNA and see if that works for my patient to have a decision making. Of course, we do not have a level 1
ctDNA
de-escalation.
today we don't have the best
Yeah,
tech
that is
and
what I
all.
was coming to, sir.
Okay.
Discussion will be there, definitely for the DMMR to use this drug, but if somebody is not willing, we will have definitely a discussion for ctDNA.
Dr. Shefali.
Sir, I have already answered.
Already answered yes. Dr. Ritu.
Sir,
Yes or no only. So we're going to go to the other trial just quickly.
I'm more in with Shefali, sir. Not for all.
Not for all.
High risk patient, yes. And look, with patients with comorbidities, I will be little.
So it is 2 not yet and 5 for comes to Viraj for the last arbitration. Yes or no?
Yes.
Yes. Okay.
So very quickly, I think for Atomic, where a lot of criticisms about the long-term IO and those stuff, I feel the take-home message, what I take, is we should try in MDT to give 2 doses of neoadjuvant rather than give 1 year of adjuvant this thing. Yes, by somehow we are not able to convince the surgeons, or if surgeons send the patient after surgery, only then, whether it is a low risk or high risk, how I take it, some amount of immunotherapy should be exposed these patients, and all the inclusion criterias, I would give them the similar Atomic this thing.
Excellent. So the point is, well-designed trial, well done, very good results, except that there is another big contender. That's the take-home here. So we'll try to do some justice to liver cancer. This is another an important data set, I would say, as was already pointed out. This BCLC, stage B has always been the fortress of interventional radiologists, and the Atizobev in the IMBRAVE 150 tried to include unresectable and metastatic settings. So we know that TACE is the standard of care. But IMBRAVE 150 first time tried to knock the door there, overall survival, PFS and ORR rates. And then the IMBRAVE 50 at the adjuvant setting again showed a relapse-free survival advantage. And this is the setting in which, now coming to the liver cancer, the central part, BCLC-B, they are not again same, uniform. You can't put them in one bracket. There is a whole range of heterogeneity in B. Actually, this is the most common patients that comes to the MDT. This is the most classical MDT patient where. So I just want you to concentrate on the middle part where the intermediate stage called B can be divided as somebody who can be operated and transplanted, somebody who is still TACE eligible, and on to the right extreme you have the same B, somebody who is not TACE eligible. So TACE eligible and not TACE eligible is what we have. So in this setting, we'll just look at some of the counter trials and come back to why this trial is important. Emerald 1, 2, 3. Emerald is where they tried to add Durva along with TACE. And this is the combo is showing a higher PFS, but it is TACE plus durvalumab plus bevacizumab. And then you go there. And then Emerald 2 is an adjuvant, so we'll just... The Emerald 3 is TACE plus Durva, tremelimumab, and lenvatinib. So a lot of drugs are put in there. So these are the most important trials which I have put on the right text, is that Emerald 1 and the LEAP. These are, a lot of things are being done there. And the Talent TACE, where TACE is another interesting trial in which TACE is given at demand. That's where you have to compare the ABC, which will come in a minute. This is the Talent TACE where at demand TACE is done. TACE will be definitely done plus atezolizumab, the same combo is done. Again, this is the PFS as it stands, but not much overall survival advantage. So that's where this design, very beautiful design, I would say. Straight away, just give this combo and versus TACE. The question that it is trying to ask is whether TACE can be replaced or not. And this is the current status. 320 patients are planned, and as of now, 231 patients are already enrolled. I think I would say for this subset of patients, it's a very good accrual, I would say. And the first interim analysis has reached, and at 33% of the events, and the second interim analysis is awaited. We don't have any argument about the baseline characteristics, exposure of treatment, and everything is. The only question is about the endpoints. The treatment time to failure of treatment is the endpoint. We'll come to that, whether that will be a good endpoint. Adverse events are all okay. I'll come quickly to the conclusions, and then I'll go with my panelists. Once again, I'll start with, I can start with you. So for want of time, I have rushed. I'm so sorry about that. I wish we had a little bit more time, but what is your opinion on these conclusions? It is trying to question that TACE can be replaced. That's what it says.
So I think in the context, given that they're also running a talent TACE and that is expected, I don't think we should be looking to replace TACE. We should be looking to improve survival overall. And that's number one. Number two is I really like their endpoint of time to failure of treatment strategy. It's a very relevant endpoint for HCC because we deal with a lot of decompensations with atezolizumab. It is not easy. Neither is TACE, I agree. But I think their endpoint is more clinically meaningful than just a hard endpoint of PFS like in Emerald-1.
Actually, the safety was very good. That was not the problem. And you remember, these are TACE eligible patients, not the TACE ineligible on the right text where you definitely can't. There are, first of all, you need to have a TACE eligible and TACE ineligible. There is a criteria called up to 7 criteria. That's how it's divided. So you will see it very commonly when you really want to sit in MDT and split. That's how it goes. This is going to be common. MDT is important. So your comments, I'm just going to run across it.
Yes, sir. So two things here. So even the patients with VP1, VP2 status were involved. So now on atezolizumab, we know there is no overall response rate comparison between the two arms. So what will be the progression? Though clinically meaningful TTFS was a good idea to have in a real world practice. But we can replace TACE is very
important. Clinically meaningful.
Yes.
Remember one more important thing which I didn't. This is a phase 3B trial. What is a phase 3B as definition? It's already an established strategy, and you want to try to extend the strategy. So you take that point and keep going on. Please, you can pass on.
Talent TACE coming, so we don't know to replace it.
So if we see the cross-trial comparison, so if LEAP-012 or Emerald-1, so they have used systemic therapy along with TACE. And then the PFS, if we compare that PFS with this TTFS, it is almost the same. So here we are using one modality of treatment and giving this almost similar result. So I would go with this study that it's a good study and it...
The least complicated multi-drug into that. That's what you want to try to say. Ritu, madam.
Yeah, same. I don't think TACE can be replaced based on this study. TACE can be replaced based on the results right now, but yes, most of the studies which we have, it's a combination of TACE with some other immunotherapy.
Yeah, I'll finish and then I'll tell my take on it.
Sir, I think we should wait for the second interim analysis data for longer follow-up before we can replace TACE. And also, sir, we have to keep in mind that it adds a lot to the financial toxicity as well, switching over to atezolizumab from TACE. Also, we have to keep.
Yes, sir. I think replacing TACE at this point of time is something that we can't do. So we will have to sequence it in a way.
So I would wait to replace it, sir.
You know what? I'll finish my take and then I'll give it to the best of us here in Viraj.
It has to
the
be
point
with the
is,
systemic therapy.
it is questioning the role of TACE. How many of you have routinely be using TACE? In a very good, well-fit patient, it's fine. But a lot of patients, the TACE, and this is a beautiful strategy of showing the treatment failure, and I think this is a most valid trial. that is trying to question the use of, and with a well-established drug program, well familiar, clearly showing the BEV component is very important, showing there could be a bit of shrinkage. There are a lot of advantage there. Whether we can shrink it and operate it and better safety profile, actually the 0.55 hazard ratio is very, very good, except one argument what I agree is that the second interim analysis is still awaited. Other than that, I think this is a very important trial, and this is an MDT, cream, I think. I have listed the cons also. Viraj, your last word.
So
Thank you.
Beautifully listed all the pros and cons. The way we treat intermediate risk is like you showed the graph, not intermediate are same. We know that the bad intermediates, the B3s and the B4s, were already part of IMBRAVE 150, right? So that's where AB works. So there's no argument about it. Now we want to move one forward to B1 and the B2s, where it stays eligible. And even from long back, I had a hunch that AB could replace TACE because, see, TACE has never shown in a randomized control fashion that it is the best thing, and it showed in the era of sorafenib. It had never to beat any better combo of systemic therapy, except in Emerald, where TACE followed by IO versus TACE alone. Their OS was not there, only PFS. But a proper trial done like this, treatment failure, I think we will see that not all of our patients who are TACE suitable should be TACEd. And IO may be a reasonable option.
Thank you. My last word on this, and I think this is a very important trial, adding, the most difficult information to come out. You have to give a chance to systemic drugs first, that's my take. And then if you win, you can convert it into resection and so on and so forth. And if you can't win, you still have, if you progress, you can always come back with TACE. And now with TACE being, multi-stage TACE, depth TACE and all, so TACE need not be going away. So why don't you give a chance to the first good opening batsman is my argument. Second interim analysis will probably say yes or no to that. With that, we finish and give it back to you on time.
The only last point, in HCC, the way diseases progress, do we want to wait till second interim analysis, or is the first interim is okay? Because a rapidly progressing disease, but that's not for me to decide. Let's move on to the second panel, and let me invite moderator, Dr. Krishna Prasad. Dr. Krishna, please come. Your panelists are Dr. Sumit Goyal, Dr. Rishabh Kothari, Dr. Manoj Mahajan, Dr. S. Krupashankar, Dr. Vivek Agarwala, Dr. Suprit, Dr. Viraj Lavingya, and Dr. Anant Ramaswamy. Anant, please come. Thank you.
Yeah, thanks to the organizers for this opportunity. So this is basically discussion on colon cancer, where we try to challenge the sequence, challenge chemotherapy itself, and challenge nihilism in BRAF positive. What does the BIKE actually stand for, Kripa?
So I think it's a Ducati, so probably it stands for fast and furious is what Vivek wants me to say. So
okay, let's rediscuss it in the end if there is time. So we know that in MS stable, microsatellite stable, this is how we proceed when patients are resectable disease. You would either resect it, and if it is obstructing, sometimes you may just do a diversion or a stent and then proceed with surgery later on, sometimes chemo and then later on. But in general, in resectable disease, surgery is the first thing. In unresectable disease, the NCCN says consider radiation plus minus chemotherapy. So this is how it has been. Now, FOXTROT tried to change it. It's a large trial. So 1,050 patients randomized operable colon cancer, T4 or high risk clinical T3, randomized between surgery followed by FOLFOX and then versus FOLFOX3. Some patients even got panitumumab if they are RAS wild type, and then surgery and then 9 FOLFOX. So we need to look at these things in this trial. Why change the standard? Is it feasible to do it? Does it increase operative complications? Does it significantly improve anything? Is it replicable? Whether there is a treatment or treatment risk, is it practice changing in some or all? Viraj, let's start with you. What is wrong with status quo? I mean, you're getting 70% cure rate. Are you not happy with it?
No, so I agree. Foxtrot we only use for T4s or mainly T4Bs, especially when the surgeon feels there is a multivisceral resection incoming. That's when we now have a data that we can do Foxtrot. So currently we only use Foxtrot for that.
Okay, so Preet, what is your thought? Why not status quo?
I agree what Viraj sir has said, that only for a select set of patients there is a need for something different, but whatever is existing, I feel it is good enough.
Okay, so if you look at it, this is a randomized phase 3 trial, large the thing. The first thing is whether it is feasible or not. So you're giving 3 cycles of FOLFOX, that is 6 weeks. Most of them completed it. Curative resection, if you see, were same in both. And only 0.4% died before surgery, which is nearly the same as 0.3 in somebody who's upfront surgery. Inoperable disease is actually less, 1.3 versus 2%. So Kripa, do you think this is a feasible strategy to give neoadjuvant, or are you worried?
So I think it's definitely a feasible strategy, but then I think patient selection is the key. I think you ought to look at identifying those high-risk patients, especially T4B or bulky nodal disease, N2 disease, and probably a doable strategy in those are probably borderline resectable, where there's absolutely no doubt that most of us would want to do that. So I think in those particular subset of patients, a select subgroup of patients, definitely a workable strategy.
So Vivek, your thoughts, perioperative complications, you're worried if you give neoadjuvant chemotherapy, or are you now pretty comfortable? You're doing it in rectal cancer. Are you comfortable?
Yeah, so I think the data is quite clear that the complication rates are not high. This is definitely feasible. And one thing that just to add to the other high risk factors is high CEA values, where I tend to tell my surgeon that the patient has very high CEA values, 100 and all, and there are no meds, so there are occult meds, so we have to do some neoadjuvant.
Fair enough. Manoj, in your practice, how difficult is it to convince your surgeon that this is reasonably all right? And with this disease, see, the primary endpoint was 2-year disease-free survival. And these are the other advantages: decreased number of T4, decreased N2, histological regression was better, R0 resection was rate. How do you convince your surgeon?
With all the data we have, for most of the patient MDT discussions, and even the newer changes we incorporate quite simultaneously. It's a small unit, so it's probably easily possible.
Rishabh, is this practice changing? 3-year disease-free survival in the MSS subgroup is 5.3%. Is it good enough for you?
So, as all the panelists told that it is more or less status quo. We were giving it for T4B as such also. Now we are just assured that we have some data to back it up. And rest of the patients we are still not giving, as I understand from all the panelists. I would agree to that.
Sumit, 5% was the extra benefit in terms of disease-free survival or progression-free survival when you added oxaliplatin. And this is nearly the same as giving neoadjuvant. So why not give neoadjuvant?
Definitely, I will agree, because the number of cycles are the same, duration is the same, but if we can give it upfront, maybe later on the patient selection or the biology, maybe we will be able to understand. It's okay with me, but the thing is, we need to, whether we can implement it in our routine practice. One is the patient mindset. Usually they come with the notion, if it is operable, just take it out. That is the biggest challenge. Second is the surgical thing. It's like surgeons, definitely the bad biology, like borderline, they will send it to us for neoadjuvant, but as a routine, probably they will not send.
Anant, how difficult is it for you to get convinced with this 5% extra benefit? Are you okay with this DFS 5% at 3 years?
So I think beyond 70%, the quantum of benefits is going to be like this only when and if it happens. That is one. 2, this is probably only relevant to proficient MMR, yes, not the deficient MMR. 3, there's actually now a meta-analysis which says that neoadjuvant is the way to go. But it's been very tough to convince our surgeons.
And that's the key thing. We've had discussions with people outside also, and they found it tough as well, where MDTs are even better established. So I think that's the key problem. The data is good. The data is very nice.
So Vivek, it's not a problem to convince your surgeons?
No, it is definitely a problem because you see, even with this data, there are 25% of T3N0 patients where you might actually observe them, where you would be treating them with chemotherapy. So that is one of the disadvantages of using this strategy, because you don't have an exact staging of the disease radiologically. It's actually a surgical staging. And you 25 to 30% of the patients you would be over treating probably. This is one of the issues.
Yes.
So yes, sir.
I think it all boils down to the radiological staging accuracy, and the authors themselves in the pilot study that was published prior to FOXTROT itself have conceded that a significant number of around 40-50% discordance exists when it comes to T stage, and EMVI is also a discordant between radiological versus pathological. So these factors we need to consider, especially in the era of increasing de-escalation studies that we are seeing.
If I can, 1 minute, one comment, please.
Yes, sir.
So we have 4 or 5 very eminent surgeons. Couple of them are tuned to doing diagnostic laparoscopy in colon. I mean, like stomach, almost everybody does. They do diagnostic laparoscopy, and then that's where we get this neoadjuvant referrals from. So that's what I wanted to add. There are some surgeons who really know about this, look at it. I just want to add that.
Fair enough. So whenever we have a single trial, we want something else to corroborate. So we have a phase 2 Prodigy trial, and one Chinese optical trial, and one Dutch NeoCal trial. And if you look at it, all of them show that it is pretty safe, because that's the first thing you want to show the surgeon, that it's a safe thing to do. And in terms of downstaging, virtually all of them tell you do downstage, but like how you pointed out, it's from radiological to surgical. The 3-year DFS was positive in only 2, not in the other 2, even though you can see numerically it was better in the optical. And like how Anant said, there is a meta-analysis which clearly shows this probably is reasonable to do, not only in terms of DFS, there is some OS data as well in this meta-analysis. Viraj, your take on this?
So yes, we have now surgeons who are doing DLAP regularly, and I think it's an excellent point. I have started getting referrals now for FOXTROT. Case ko FOXTROT kar dena aur fir bhejna. And but the choke point still remains the surgeons, that if it is not, see, rectum they changed because there was a stoma, no stoma story. Colon, there is no such story. So that 5% DFS, it's very hard to push down that for this we want to give chemo.
So we should be clear that we are not misunderstanding the surgeon when he says do FOXTROT. It's a dance move, which is a very famous dance. So you need to look into that. They may be hinting at something else. So if you look at this FOXTROT randomized phase 3 trial, there was no statistical overall survival benefit. Kripa, what do you think? It's too early, that is why we're not seeing, and maybe it is separating. You may see it in the long run.
So I think probably for me, the risk of over-treatment still remains, I think, for a certain subgroup of patients, because even with the IDEA meta-analysis, we talk about stage 3 low risk and high risk, where we talk about the duration of adjuvant chemotherapy being 3 months or 6 months. So I think that's where probably the one glitch is. Like I said earlier, probably you'll have to look at identifying those high-risk patients. Even with, we're talking about, in the current era where we're doing ctDNA analysis as well in the adjuvant setting. So I think that's probably where, we're looking at selecting this very high-risk subset of patients who would definitely probably benefit from this strategy.
Vivek, you made this point, 11% refused chemotherapy because they were too unwell, or at least they thought they were unwell. 16% were not given chemo in the upfront surgery because it was considered low risk. And even in the other trials, roughly 25% may not have even required chemotherapy. So you stick to this fact that you are worried about over-treating patients?
Yeah, correct. I think everyone has resonated that they are applying this to their own clinically high-risk T4Bs, N2s, nodes going into the mesentery, where the surgeon himself is not confident of a R0 resection. So that is the reason why, because if you apply it to all, then definitely there is a risk of over-treatment to many patients.
Rishabh, your thoughts on this? So both the optical as well as the this present FOXTROT trial, they tried to pick up patients. They are also worried about over-treating. And can you comment on this, the subgroup analysis on both?
Yeah, so the upper part, we can see that T4 and N2s are the one which are benefiting the most, and which is what is expected, and as such also we were trying to do that in a lot of them.
So I think, Manoj, you also agree that you would want to select T4 and N2 disease, and it may not be easy to do it on CT scans.
Yeah, it won't be easy, but that is the whole purpose, hyper-selecting the patient.
So basically, I think we know that doing this neoadjuvant chemotherapy is safe, feasible, not detrimental. Not very sure whether it is more effective in all, and we are worried about over-treating. And NCCN does consider this for clinical T4B or bulky nodal disease. How many times do we see NCCN pick up a subgroup in a clinical trial and actually put it there? Generally, it will be blanket statements, isn't it? So in fact, there are FOXTROT 2 and 3 trials. The 2 is just an extension of this, whereas 3, they are trying to use FOLFIRINOX. Sumit, your thoughts on this FOLFIRINOX upfront?
I think that will be overkill, according to me. I'm not convinced for, at one place we are talking about de-escalation and...
Okay. So now let's go to the next one, the NICHE trial. So now we are trying to break the sequence. Now we are trying to break the chemotherapy itself. Now NICHE started as a protocol trying to look at the safety. They took up 33 patients and tried to see whether it is safe to give 2 cycles of immunotherapy. And then they extended it to the NICHE-2, where they, I think, had 100 and odd patients. Anant, can you just explain what type of trial this is and tell us the results?
So one, it's straight up a remarkable study, irrespective of the stats. I mean, this is pretty much a game changer. And I think for those interested, they should read Dr. Chalabi's initial idea behind NICHE. They were not looking at DMMR. They were actually looking at PMMR, and this was an unintended positive side effect that the DMMRs did so well. So, I think, everyone here knows it. It was briefly discussed also by Raja sir that, this is probably the way to go in these patients. Beyond that, I think this has been discussed.
So this became the famous, Miriam Chalabi plot. And they hardly see anything like this. With the, there was one patient who had more than 50% residual viable tumor with just 2 doses of immunotherapy. And even that patient doesn't have progression at the end of 3 years. So the 100% 3-year DFS is still maintained. And like how I think sir has already pointed out, the circulating tumor DNA was also negative at 3 weeks after surgery. Now there are other trials as well. So Anant, if you can say, are you happy to have other trials, or you really didn't need any other trial for this?
So I think the idea would be that do all patients need 2 drugs? So, would a single drug probably maybe bring some kind of response is interesting. I think the ctDNA concept can also be taken forward in those trials as well. If there are more ctDNA positives with a single drug, then that probably 2 drugs is what you require. And of course, in our setting, in the current era, when you have drugs beyond Nivo and Pembro, are those drugs equally good in this scenario? I think these are the kind of unanswered questions, because you can't get better than this in terms of outcomes, I think.
Yeah. So I think ESMO this year, they also compared it with the FOXTROT, and they showed that NICHE, like how sir has already pointed out, there is a significant difference. So would you do neoadjuvant immunotherapy to all? Virat, what would you do? Why not give it to everybody with such great results, 2 cycles? Are you over-treating?
Definitely we are over-treating the T2N0s and T3N0s. So, and unfortunately, radiology will never be like rectum cancer. We have MRI there, where staging accuracy grows above 90%. But in colon, with CT scans, you would still be off by 30 to 40%. So that's the only bad part about NICHE-2. Otherwise, you can't beat 100%.
Yeah, I think radiologically it's extremely difficult. When they did the FOXTROT trial, They initially thought that the high risk T3 is more than 5 mm, and then they said even 1 mm is high risk. So it's very difficult, I think, beyond the cirrhosis, isn't it? So Preet, what is your thoughts? Now that the NCCN says, again, clinical T4B or bulky nodal disease in a DMMR, it says you can also give FOLFOX or Capox, or you can consider neoadjuvant immunotherapy.
No, sir, I'm comfortable with the NICHE-2 approach because I don't want to definitely, knowingly that these patients are unlikely to benefit from chemotherapy, which was what was discussed with ATOMIC as well. And I'm just doing away with two cycles of immunotherapy, and that's it. And we are seeing a straight line. And this is something phenomenal, and I'm very convinced with this data.
So we'll not go into the ATOMIC. I think this is already, the elephant has been thrown out. So except when you are not able to convince the surgeons, or you were not convinced that the patient actually had little bit advanced disease and you pick it up after surgery. So Kripa, see, FOXTROT is going ahead with 12 weeks of dostarlimab, surgery and another 36 weeks of dostarlimab, or 48 weeks and nothing. So, and also NCCN guidelines doesn't say Nivo-EP is the way to go. Neoadjuvant immunotherapy, and these are all the options. So what is your option?
So I think for a DMMR patient, definitely IO is definitely going to be part of my routine standard. But as far as non-operative management is concerned, I think that needs to be really detailed in discussion with the patient across the table, and then take a call on whether the patient is actually willing to go through that intensive surveillance protocol. But for me, if I just want to add, probably NICHE was phase 2. Just one word of criticism there. And the other thing is, we have the data now in the metastatic setting where we're looking at adding chemotherapy to IO, the COMET study. Again, Atiso plus chemo. We saw, right, there was a lot of criticism of Atiso being a weaker drug, probably PD-L1 versus PD-1.
You said Atiso is a weaker drug?
No, I mean, at least as far as the COMET was concerned.
Okay.
I don't think there are any Roche people here, but nevertheless, still I would say that. Stick my neck out and say that. But I think, jokes apart, this concept of probably trying to look at adding chemo to IO, and probably you could do better there, is something that needs to be explored in this subgroup of patients as well.
Vivek, he wants a phase 3 trial. You want to do it?
I really don't know, whether this will matter anymore, because...
Will you get it through your...
Yeah, because this is very, very good data to, to establish the fact that and we all know immunotherapy is something that is going to work well. So it is all about patient selection, that, the lower risk ones you want to leave out and the higher risk ones you want to take it for this strategy. Another one thing that I think this trial showed was that the radiographic response didn't correlate with the pathologic response. So the radiographic response was just 2 or 3%, but the pathologic response was something 65%. And this is one thing that you want to take away from an MSI high disease, where a bad radiological response or a no radiological response doesn't always mean that patient is not doing good. So this is one good take from this study.
Yes, Manoj.
I'd like to add just the data is good, but I think we should integrate this with the ctDNA. I'll practice this, but I would like to have more data based on the ctDNA, because this, as it's phase 2 single arm study, we need to validate more with additional ctDNA data in expanded studies.
Rishabh, what would you do? Would you give checkpoint, and which checkpoint would you give?
So I would go as per NICHE-2 whenever feasible. And if it is, I have to give it in adjuvant. If patient has been operated upfront, then ATOMIC is the way as of now. We would have questions whether we can replace checkpoint inhibitors, or we can use optimally the dose modified ones. That we are yet to answer. But as of now, if given a choice, NICHE is the regimen that I would prefer in.
So Sumit, would you think about a phase 3 trial? Would it pass through the ethics committee with this kind of difference? In that FOXTROT, the response rate was 7%. And here you have some 67 pathological complete response, 95% major response. How will you convince the ethics committee? Do you think you would want to do it?
Doing this kind of a study will be difficult. One, number of patients will be very less, and accrual will be over a long period of time. Second thing is whether to do it. See, the data in phase 2 is good, and we can, I think, implement. The question comes to which drugs. That again, it will, even if we do a phase 3 study, we will still be like, cannot extrapolate one IO to the other.
So I think it's going to be difficult. It's like the APT regimen in breast. I don't think you will get a phase 3 trial. Yes, Supreme?
But to the point of choosing dual versus single agent,
Yeah.
we already have this debate going on in the metastatic setting, Keynote
Yes.
177 versus Checkmate 8HW. I was a few months back reading an interesting pro and con published on Annals of Oncology, and there it was neatly pointed out that there are certain subset of patients who were included in the Pembro trial who had shown early disease progression. It was 30% in the Pembro trial versus 15% in the 8HW. Again, this is a cross-trial comparison, but still we do find certain subset of patients who do not respond to single-agent immunotherapy.
But that was in the metastatic setting.
Fair
The
enough.
patient subsets were totally different. The microenvironment, the peritoneal disease, the liver mets, they all tend to do poorly.
Anant, your thoughts on any of these small subgroups? I mean, I just put it up just to show that I also read the supplements, nothing else.
Thankfully, even I read the supplements, so it doesn't look very unfamiliar. Not too much. I think just overall, it just shows that it works. The point to the phase 3, I mean, I think this is one of Viraj's lines, that phase 3 is only for losers. That's something he once told me in immuno, right? I think 100% is enough.
Absolutely.
We
Yeah.
shouldn't dig deeper.
Yeah, any reason why the Lynch, did
Yeah,
have
actually,
better as
I wanted to point that out to Virat, that there are some data sets to say that Lynch, actually do better compared to the non-Lynch DMMR. In fact, in other trial as well, there was one more trial where it did that. I think it's confusing, basically.
For now, we will not take a call on the Lynch versus non-Lynch.
yeah.
We need to treat all of them, I think.
I think one thing that we can also take away is that we are all moving to perioperative immunotherapy strategy rather than the adjuvant strategy, whether you take it colon, whether you take it lung, whether you take it head and neck. And this is because you want to give that 1 or 2 cycles of immunotherapy in the neoadjuvant, because you want to, immune prime when the tumor is still there. You want to prime our body, the immune system for taking care of the MRD. So that is
Also,
how
I
it's
think
evolving.
the toxicity would be much less, isn't it? Giving only 2 cycles. Out of all those 100 and odd, I think only 1 or 2 delays were there. And in fact, both of them were for immune-mediated myositis. I mean, that was a reason for delay. So I think, so it's extremely easy to give. Nobody wants to give 1 year, 2 years of immunotherapy and get all the toxicity. Here it would be much less. So we all know, finally coming to the last one, that BRAF mutation status always makes the disease pretty bad, and hence we want to improve on it. The FOLFOX6 combined with encorafenib plus cetuximab, this is the progression-free survival and the overall survival response. Viraj, your thoughts on this, PFS and OS?
So it's a practice changing. The only thing is we don't have ENCO. So I use Dabra Tremi in my practice, but same strategy.
So you use Dabra, Tremi, cetuximab,
and
FOLFOX6. What about the toxicity? Because this
rash,
is one of the...
Rash.
Rash everywhere.
Lot of rash.
Okay. But
so we don't know that.
In metastatic setting, we have done away with Tremi. So why use Tremi?
The original DPT combo has still stuck to me. That T part is still important. So I only use 0.5 milligram, small dose of MEC.
0.5 milligram?
Instead of full 2 milligrams.
Oh, okay. Okay, Supreet, you are happy with this? Overall survival, everything is on one side.
Yes,
and
sir.
this is an extremely bad disease subset. So you'd want to do everything, but generally you can't do everything much because you don't have the drug easily available. You can import it, but it will make a big hole in the patient's pocket, isn't it?
Dabra Tremi in India is reasonably good now, since the Novartis has handed over these products to an Indian company. So it's very much well within the reach.
Yeah, Kripa, this subsequent therapies, when you are treating these patients with such a toxic regimen, you don't want to, actually make it more toxic and then say, okay, maybe the patients did not receive it, they could have received it later on. But this clearly proved that, most of the patients, 100 of them actually received a BRAF inhibitor out of 139 in the control arm when they progressed. So you're happy with this? Does this, make this data set very strong?
Yeah, it definitely does. And if you look at the beacon and then the breakwater, we've shifted from second line now to the first line. And for me, I think what's very interesting is the rationale behind this. Because, the conventional teaching has always been like EGFR inhibitors do not work in BRAF mutation. But here we're talking about the reconstitution or reactivation of the signaling pathways that can happen. And that's why you have total blockade, BRAF plus MEK plus EGFR. And like Viraj rightly said, the downstream signaling pathways can still be active. You can have second malignancies like skin cancers, which is why the rationale was to add a MEK inhibitor as well. Agreed that the efficacy did not matter much as far as showing a PFS or overall survival benefit with the third agent, which is why probably, just a BRAF plus EGFR inhibitor alone is probably good enough. And even in this trial as well, they had a third arm, which only looked at encorafenib plus cetuximab. And there, I think, that the survival is not statistically significant, but still 19 versus 12 months was clinically probably meaningful in patients who probably will not be fit enough to receive chemo and probably only want a BRAF plus EGFR inhibitor.
Vivek, your thoughts on this, that, it's pretty large number getting it in the next line.
Yeah, so it's a wonderful strategy. I've already used in 2 patients, and what I used was dabrafenib plus panitumumab plus chemotherapy. There is a phase 2 data of dabra plus panitumumab, and both the patients are in CR and doing well. So I think this is the go-to strategy.
And the dose of dabrafenib?
So I think it is 150 BD. Yeah, 150 BD was the dose. Same.
Fine. So Rishabh, what about the grade 3 toxicities? So, 81% had grade 3 toxicities. You're worried?
So we know that with this regimen, even in other situations, we expect this toxicity, but we have to learn to manage this toxicity because you have a overall survival benefit. So it is more of us learning, being aware, and telling the patients what to expect.
Fair enough. Manoj, somebody has already received Folfox or Xelox in the adjuvant setting and now progresses and BRAF positive. Are you comfortable substituting Folfiri, for example?
Yes.
So there was a cohort 3, isn't it?
Yes, chemo backbone is still, the results are because of the chemo backbone. So we need to give the good chemo backbone when already the pre-existing has been used.
Yeah. Sumit, your thoughts on this? You would change to Folfiri. There is a cohort 3.
Yeah, definitely cohort 3 is there. The results were not they were not equivalent to Folfox, but they were comparable. And just EC definitely I will never use alone.
Anant, your thoughts? NCCN guidelines have already come into this now. And also, FOXTROT 4 is trying to use it in an operable colon cancer with 6 weeks of encorafenib, cetuximab without chemo, surgery and then chemo. Your thoughts on this future?
So the FOXTROT guys are brave people.
Yeah, they are.
They're doing the dostarlimab also without surgery. They're doing this one as well. 2 points here I'd like to make. I've used this in patients who've imported it. Now 5 patients. All of them I've had to bring down the encorafenib dose from 300 to 225 and 150. So it's only 5 patients, but I think that is one. 2, the Dabra-Tremi, as per FDA, is not approved in BRAF mutant CRC. I guess you could substitute it because we don't have an option, but the whole medico-legal thing is a little worrisome. It is not, specifically they have said no. I don't know why exactly, but they have specifically said no. So yeah.
I think we'll end here. Treatment goals in locally advanced colon cancer. Now, on one hand, we want to de-escalate, and on the other hand, you want to intensify treatment. The idea is to reduce toxicity, improve survival, keep the patient's preference in mind. With that, I have 1 second and I hand over to the organizers. Thank you. Pardon? Oh, the bike, I don't know. I just put it there.
Okay. Thank you so much, all the panelists. Women power, absolutely. Can I request Anant? And Anant, you will have to give take-home messages from both the sessions. Atomic versus niche and DMMR versus PMMR was something which they were speaking. In addition to that, where are we with FOXTROT? And in HCC, is it now the time where if the patient is having proper TACE eligibility, still we think of systemic treatment? Over to you, Anant. Yeah.
Morning, everyone. So this take home is not much of a take home because everything has been discussed by Raja sir and Krishna Prasad sir. So, but I'll just put forward my perspectives. They are not take home, it's just perspective. So the first thing is that the HCC study is actually an investigator initiated study. So, kudos to Roche for actually supporting this, and they're multicentric. India is one of the centers. They're actually looking at other centers as well for being part of the study. They had great stats. The stats, they wanted to improve their endpoint from 9 to 12.5 months, which is actually good. That's a reasonable assumption. And one important thing is they included B7 as well. I think that's noteworthy because a majority of these HCC trials don't include B7. So I think that's important. The cons really is that I think, again, the TTFS is an endpoint. It has not been used commonly in trials, but I think in the future, this is the endpoint to use. It is a good composite endpoint for HCC, which takes into account everything. The other thing is that for the full trial to accrue, you need close to 320 events. The number of events now is only 100, so I think we need to hold our horses. Still, if the study is also positive, I don't think we will replace one with the other. It will be addition of taste to systemic. How you sequence it, I think in those, and I think this was pointed out in the discussion as well, that if you have multifocal, multinodular, infiltrative disease, probably systemic first. In all the others, taste first. I think that's what we will end up doing, irrespective of the results of the trial. Coming to the breakwater, the only point I want to make is that not all BRAF is bad. There are those groups of BRAFs which are not bad also. So this is just data to show that if it's not a V600E, some of these patients actually do well. So, it's not a blanket bad boy. The study itself is awesome. I mean, earlier survivals with BRAF mutant tumors were less than 12 months, and you're now going to a PFS of more than a year, which is, pretty good. The availability, of course, is still an issue, but I think the toxicity, all that, is manageable when you're having such kind of survivals. So I think this is the way to go. So just a show of hands for the audience. If you had no logistic constraints, would all of you use this? Great. Assuming this becomes standard of care in our country, how many of you will be able to use it? Okay. I know you would put up your hand, Amish sir. Yeah. So the major thing is going to be the cost. I think we would all want to use it, but the cost, I think, is going to be an issue. The only other flaw is, could they have used FOLFIRINOX plus BEV as a comparison? Because that was the most effective regimen in BRAF mutant. But I think that would have been too brave of them, and it would also not reflect clinical practice because only 20 to 30% of our patients are fit for FOLFIRINOX. So otherwise, I think this is great data, is the way to go in the future. Coming to the FOXTROT, I think this was really well discussed. These are the two important points that I could pick up. One is the survival, and two, does anyone believe that pathological response in colorectal cancers has any relevance? So again, questions to the house. Are you convinced on 2-year RFS as an endpoint in stage 3 colon cancers? Anyone? No one believes that 2-year RFS is an endpoint, is a good enough endpoint in colon cancers. No, stage 2 and 3. No, okay. So that's a problem even I thought with the trial. The median follow-up is 3 years, but 2-year RFS is not good enough. So how many of you will use it, assuming you're able to convince your surgeon on Monday morning? Okay, that's a resounding no. So none of us are able to convince our surgeons. Okay. And I think pathological regression rates is plus minus in colon cancers. So what we do at TMH and what our surgeons are also convinced on is what was again discussed. The T4, where multivisceral resections, vascular resections are being planned. When there's doubtful peritoneal disease, that's where we do it. And there are those cohort of patients who are surgically unfit initially, but are still stage 3. That's again somewhere we use this approach. Again, this meta-analysis was highlighted, and I've shown you data for R0 resections, surgical resections, disease-free survival, overall survival. So whatever endpoint you want with the neoadjuvant approach has been achieved. So per se, in terms of oncologically sound endpoints, this is a valid approach. Whether we can do it or not, I don't know. Coming to the atomic and niche, I think this has again been discussed so much over the last 6 months, not too much to add. One thing is that FOXTROT probably should not be used in deficient MMR. I think survival as well as the pathological response rates are less when you use chemo in MSI high, so let's not do that. So, the comparison is this. And to me, with the 3-year DFS outcomes which have recently come, I think irrespective of the radiological flaws with CT scan, the way to go is neoadjuvant. I mean, we will not have phase 3 comparing these approaches. You cannot get away with less than 1 month of therapy in any tumor. And that's what NICHE shows you. So if you have even some doubt on T3 and beyond, I think the way to go is immuno. What drug, what combo is something we'll have to find out later. It's just not, Ipi-Nivo, there are a number of trials actually, and this is what I was referring to. Almost all these trials are looking at MSI high tumors as a neoadjuvant option. So we will have some answers on drugs like toripalimab. We will have some answers on single immuno as well for resectable colon cancers. So what we do is that as of now, we try and take everyone for niche. But in case that is not possible, only the T4, N2 or impending obstruction is where we say, okay, let's get it operated. All the rest we take towards niche. So with that, I'd like to thank you for your attention. Thank you so much.